Hi, my name is Megan Campbell, and I am a student in the BSN to DNP program here at KU in the Family Nurse Practitioner track. For my Principles of Epidemiology project, I decided to ask the question, does access to emergency contraception impact unintended pregnancy rates? So first, when looking at this question, we have to look at the significance of the exposure. So family planning is a topic area of focus in Healthy People 2020. And while I'm sure most of us are familiar with Healthy People 2020, for those that aren't, just kind of a brief overview of it, it's basically um, a landmark document and kind of a program put forth by the U.S. Department of Health and Human Services to guide um, essentially the health of the nation. And so they have these topic areas of focus, and then within each of those, they have more specific benchmarks and how to address those areas. So for example, what I have listed next is FP, so family planning 3, so it's the third goal. And that goal specifically is relevant to the question I asked, as it states, increase the proportion of publicly funded family planning clinics that offer the full range of FDA-approved methods of contraception, including emergency contraception on site. And then the next piece of significance for our exposure is that emergency contraception can prevent over 95% of pregnancies when taken in appropriate timeframes. And the timeframes vary on the specific medication, but typically as long as it's taken within about 96 hours for the majority. And the use of emergency contraception is indicated in several situations. So, for example, after method failure or unprotected sex or situations of rape. So, the significance of our outcome is that unintended pregnancy has huge impacts throughout our society. So, first, starting at those most intimately connected with the unintended pregnancy. So, the woman, the father, and then the child that's resulting from the unintended pregnancy. So, for example, in terms of the women in this situation, they're more um, likely to be victims of domestic violence, higher rates of depression, and then more often they have a delay in prenatal care or inadequate prenatal care, even. And so this has effects then on the baby, different poor health effects from not having adequate care and nutrition and counseling during the pregnancy. They also have more poor health outcomes in childhood. And then the men who are fathers of unintended pregnancies typically earn less money or have less education, earn less money, and therefore get stuck in socioeconomic burden of less access to health care and then poor health outcomes. So, additionally, unintended pregnancies have impacts on those that aren't directly involved in it. So, in 2010, it was estimated that unintended pregnancies resulting in childbirth had a monetary public cost of $21 billion. So, what's interesting to note is that in 2010, for every $1 spent on family planning services, the government, so it's state and federal levels combined, saved $7.09. So, this really is a good example of Ben Franklin's famous quote, an ounce of prevention is worth a pound of cure. So, here's a summary of the articles that I looked at. So it was kind of interesting to note two of my studies were randomized controlled trials. One was a retrospective cohort. They all had pretty specific age ranges, with study 1 and study 3 having the most similar. Study 1 had females ages 15 to 44, study 3 had females ages 18 to 45. Study 2 had a smaller age range, females ages 15 to 24. So the exposure was measured kind of differently between the three. So in the first article, data was taken from the health system medical record in a retrospective chart review. And then in study 2, participants were assigned to one of 3 different access groups for the emergency contraception, or as it's abbreviated in the literature, EC. So that's what the abbreviation on my tables are. Um, so pharmacy access to EC, advanced provision of 3 packs of specific type of EC, or clinic access. And clinic access was the control group for that study. And then study 3, the participants were assigned to intervention where computerized education was given regarding EC, and the participant was provided with a sample of the EC that that they were taught about on the education. And then the control group in that study was had a computer tutorial that was about a certain vitamin, and were provided that. And so then, in terms of how the outcome was measured, in Article 1, the question on a prenatal intake questionnaire regarding pregnancy intentions was on there. And then in the study 2 and 3 both used self-report. Study 2 was via a questionnaire administered by research assistants at a clinic or in the participant's home or by telephone. And study 3 was self-report via questioning from a research assistant by phone. So strengths and weaknesses of these studies, they all really had a very specific population that they were looking at. So in some ways that's a strength. And so study 1 also was completed within a healthcare system. And so they were able to capture participants at several different access points of healthcare. And they were able to control for factors to make it applicable across age, race, and ethnicity, which was interesting. Weaknesses of study 1 were that timing regarding events that led to needing to use the EC was not always specified. And then since it was only looking at participants in a specific health system, any pregnancies that were terminated at facilities that were out of that network were not known. And then they also noted that they weren't able to calculate the EC efficacy. And then self-report was used to measure outcomes. And study 2, some of the strengths of that were the outcome of pregnancy was less susceptible to recall bias, and the responses that were also assessed by biomarkers to help corroborate. And then supported the hypothesis that unsafe sexual behaviors are not linked to EC access, which is important because while it's not the question that I asked, it is an argument, a piece of argument that's used by those who are against more open access to EC. A couple weaknesses for this study: self-report was used to measure outcomes other than pregnancy. Because remember, the pregnancy was used by biomarkers as well. And then the study was conducted in a clinic population, so it may not be reflective of those without essentially a medical home. And study 3, a strength of that I thought was interesting was one of the clinics were part of an academic medical center, and the other was affiliated with a county hospital. Self-report was again used to measure all the outcomes, and population loss to follow-up may have resulted in an underestimation of the benefit for the counseling intervention. So the Hennequin's criteria, the main thing to note here is that Article 2 and Article 3 were not statistically significant. And their measure of association, odds ratio, the strength of it was none, essentially. Article 1 did have a statistically significant p-value with its confidence interval, and the measure of association was weak. So an overall summary of the articles, like I said, one of the 3 studies supported a statistically significant association, but the other 2 did not, and that's between access to emergency contraception and prevention of unintended pregnancy. But while only one showed any sort of association, it's important to note that harm was also not shown by having increased access. So you could make the argument that less restrictions would only serve to benefit, or less restrictions on the access to emergency contraception would only serve to benefit public health because, again, no harm was being shown. So, public health implications. Emergency contraception is a significant resource for pregnancy prevention, but in order to benefit from a resource, somebody has to be able to access it. So, again, making the access greater would be a greater impact on public health. Social determinants of health contribute to a lack of access to emergency contraception. And that's just kind of interesting to note because, as we all know, social determinants impact access to all other aspects of healthcare. And so it's kind of a positive feedback loop, essentially, of poor health outcomes. And disparities in access to healthcare can be connected to disparities in health outcomes. And like I said, it's just really a positive feedback loop. Prevention of unintended pregnancies would then result in less cost burden on the societal level. And as we talked earlier, there's pretty astounding economic figures. So, suggestions for future research. A retrospective study of those with unintended pregnancy to be conducted with how many felt they had access to emergency contraception. And then another piece that would be interesting to examine would be male knowledge and attitudes of emergency contraception, as well as awareness of access. Because, maybe if more females who encountered unintended pregnancy felt like their male partners were educated and aware of this method, maybe it would be seen as more of an option for couples in these situations. A study to determine if primary care providers routinely discuss emergency contraception when discussing family planning with patients. Most of the time, it seems contraception as a whole is discussed, but not necessarily the what if it doesn't work as you intend and whatnot, just making patients aware of their options. And then here are my references. Thank you for listening.